Hello everyone, I'm Professor Kevin Fenton, the National Director of Health and Wellbeing at Public Health England. We're here to talk today about antibiotic resistance and the rise in antibiotic consumption. Public Health England has just launched its second edition of Health Matters, which focuses on what we know works to improve prescribing. I'm joined today by Professor Anthony Kessel, Director of International Public Health at Public Health England, Professor Alistair Hay, GP and Professor of Primary Care at the University of Bristol's School of Social and Community Medicine, and by Dr. Susan Hopkins, Consultant in Infectious Diseases and Microbiology and Healthcare Epidemiologist at the Royal Free London NHS Foundation Trust. Anthony, let me begin with you. What's the scale of the problem that we currently face with antibiotic resistance?
Thank you, Kevin. I'd like to make 4 points. First, the antibiotics that we use are under threat due to increasing amounts of bacteria that are resistant to them. In England, over the past 4 years, there's been a 6.5% increase in antibiotic consumption, with most use in general practice. Next, the number of individuals with antibiotic-resistant infections has increased substantially over the last 5 years across a number of infections. The third point I'd like to make is that the more we use antibiotics, the less effective they become against their target organisms, because antibiotic use gives resistant bacteria a greater chance to survive and spread. And last, we all have a role to play in solving the problem of overuse, whether we're a health professional, a health leader, or indeed a patient.
I'm a GP, and in general practice, there's quite a variety of antibiotic prescribing levels across England, suggesting that there is some unnecessary or over-prescribing. In fact, in some practices, rates are 40% higher than in others. From the public's point of view, a third believe that antibiotics are necessary to treat coughs, colds, and 1 in 5 expect antibiotics when they visit their GP. In fact, estimates suggest that as many as half of all patients who have visited their GP with a cough, cold or flu leave with an antibiotic. We all feel awful when we have one of these infections, but taking an antibiotic for most of us won't change that. It just alters the bacteria in our bodies, killing the healthy bacteria and allowing the bacteria that are resistant to the antibiotics to become predominant. This means that when we do need an antibiotic, it's less likely to work. And there are 1 or 2 traps for the unwary. For example, although most coughs, colds, sore throats and ear infections make us feel awful, they will get better without antibiotic treatment. But if an antibiotic is used, some patients will incorrectly conclude it was the antibiotic that made them better. And that perpetuates the belief that an antibiotic is needed for further similar illnesses.
So thank you both. Clearly this is a challenge in general practice. But Susan, could you speak about the situation in the hospital settings?
Yeah. Every week in hospitals, I treat young women with last resort antibiotics for urinary tract kidney infections. This is frequently because they have already received an antibiotic in the community in the previous 1 to 2 years for another infection, usually a kidney infection, but maybe something else. And that has wiped out the susceptible bacteria and allows the resistant bacteria to grow and flourish. Rather than giving them a simple 3-day course of antibiotic tablets to treat the infection, they end up sick in hospital, often with sepsis, requiring 7 days of intravenous antibiotic treatment, or having to come back on a day-to-day basis to the hospital. Broad spectrum and often last resort antibiotics are used much more frequently in hospitals. This is driven by patients presenting to the hospitals with life-threatening infections such as sepsis. In many cases, they will have had antibiotics in the community that have not worked. The priority for hospital prescribers is to treat that patient aggressively when they see them, but use their laboratory facilities to diagnose what infection is this that's being caused and what's the best treatment. And therefore stopping, if it's not a bacterial infection, the antibiotic that they started, or alternatively reducing it to the narrowest spectrum antibiotic that can be used. The spread of resistant bacteria is happening quickly, and antibiotic resistance in E. coli, the commonest bacteria causing sepsis in Europe, has dramatically increased. Across Europe, it is estimated that 25,000 people die each year as a result of hospital infections caused by 5 key resistant bacteria, including E. coli.
So Anthony, not only is this in Europe, but antibiotic resistance is a global problem as well. Can you tell us a little bit more about it?
Yes, absolutely. There is a global concern about antibiotic resistance across richer and poorer countries. And in 2015, the World Health Organization launched a global action plan to combat the problem. I mean, the problem is compounded by the fact that the discovery of new classes of antibiotics is at an all-time low. And it's been 30 years since a major new class of antibiotics was discovered, which means we must preserve what we have. Now, if I can just give you one example of the problem. In 2013, there were 480,000 cases of multi-drug resistant tuberculosis. In some countries, it's becoming increasingly difficult to treat this MDR, or multi-drug resistant TB. Treatment options are limited, recommended medicines are not always available, and patients experience many adverse effects from the drugs.
Thank you, Anthony. So we've discussed the nature and scale of the problem of antibiotic resistance. I'd now like us to discuss some of the possible ways to counter it. Now, Susan, didn't the recently published ESPAR report, which you led, speak about this issue?
It did. The English Surveillance Programme for Antibiotic Utilisation and Resistance, or ESPAR for short, is a programme developed by PHE to improve the surveillance of antibiotic resistance and antibiotic use data, and to support interventions and toolkits to improve antibiotic prescribing in general practice and in hospitals. Antibiotic prescribing to hospital inpatients increased significantly by 11.7% and to hospital outpatients by 8.5% between 2011 and 2014. Secondary care hospitals prescribes the highest proportion of broad-spectrum antibiotics. Almost 1 in 3 antibiotics used in hospitals are broad-spectrum. Hospitals need to focus their antibiotic stewardship efforts on ensuring that these drugs are prescribed for the right reason and the right duration. This will ensure that these last resort antibiotics are used appropriately and can be preserved for when they are really needed. Alistair, what are the learning points in primary care?
So I think there are 2 main points to highlight. First is that healthcare professionals should prescribe only when patients have clinical symptoms that meet specific criteria. For example, those laid out in the recent NICE respiratory tract infection guidelines. And they should prescribe for the shortest duration that is necessary and occasionally consider delayed prescribing. Most patients without underlying chronic illnesses who present to their GP with coughs, colds, sore throats and ear infections won't benefit from or need an antibiotic. But in a minority of circumstances, and where there is some clinical uncertainty, there is evidence for delayed prescribing. And this is where a GP will write a prescription but advise the patient not to use it immediately, but to wait and see, and only take it to the pharmacy if their symptoms subsequently worsen.
So thank you, Alistair. Now, Public Health England has developed 2 national toolkits to help reduce antibiotic prescribing and to support improved prescribing in England. Anthony, can you tell us more about these products?
Yes, of course. These are important. These 2 Public Health England toolkits are endorsed in the NICE guideline on antimicrobial stewardship, which recommends that primary care and secondary care healthcare professionals assess their antibiotic prescribing rates against others. One of these is called Start Smart Then Focus. It's for secondary care, and it's an antimicrobial stewardship toolkit for English hospitals. Its recommendations include not starting antimicrobial therapy unless there's clear evidence of infection, and then reviewing the clinical diagnosis and the continuing need for antibiotics at 48 to 72 hours and documenting a clear plan of action. Now, from the ESPAR report that Susan mentioned, we know that 46% of hospitals had an action plan to implement their antimicrobial stewardship toolkit. So we are making progress, but there's a lot further to go. The second toolkit, Kevin, is one for primary care, and it's called TARGET, which stands for Treat Antibiotics Responsibly, Guidance, Education, Tools. Alistair, do you want to perhaps say a few words about the usefulness of TARGET in primary care?
Sure. So Target is designed for the whole of the primary care team, both GP practices and in the out-of-hours setting. And it aims to help prescribers and patients change their attitudes, social norms and their perceived barriers to optimal antibiotic prescribing. We mentioned earlier that some GPs can feel pressured to prescribe. Well, the Target Toolkit includes leaflets designed to be shared with patients during the consultation, which aim to improve patients' confidence to self-care and to improve prescribers' communication with patients. The NICE guideline on antimicrobial stewardship, which I led, also recommends developing systems to provide regular updates to individual prescribers and their prescribing leads on their individual prescribing, so that it can be benchmarked against local and national antibiotic prescribing rates and trends collated by Public Health England.
Thank you, Alistair. Now, at this point, I want to mention the Antibiotic Guardian campaign that PHE has launched. It's a campaign designed to raise awareness of the risks posed by antimicrobial resistance and to change everyone's behaviours around antibiotic use. Now, as well as awareness raising and education, the campaign engages directly with both healthcare professionals and members of the public, encouraging them to become antibiotic guardians by choosing a tailored pledge about how they can personally make better use of antibiotics. So, for example, the consumer can make a pledge that for infections that our bodies are good at fighting off on their own, like coughs, colds, sore throats and flu, they will try treating the symptoms for at least 5 days rather than going first to the GP. A community pharmacist could pledge that every time a consumer or customer presents with a self-limiting respiratory infection, they will use patient information leaflets to explain the potential duration of illness and how to treat their symptoms.
And a hospital nurse could pledge that every time they give antibiotics, they will prompt the prescriber to review and document their antibiotic decision.
So, thank you everyone. We've talked about the scale of the problem of antimicrobial resistance and how there are measures and practical steps that can be taken in both primary and secondary care. But of course, there are many other types of stakeholders who have a role to play in tackling antibiotic resistance. What are some of the roles of these other stakeholders?
Well, local authorities can work with stakeholders to provide information and advice to the public about when antibiotics are necessary and why their doctors might decide against them. CCGs can work with local acute trusts to ensure effective antimicrobial stewardship and to support the implementation of the NICE guideline on antimicrobial stewardship. And healthcare professional undergraduate and postgraduate training curricula can include topics on antibiotic use and resistance.
And directors in every area of healthcare delivery should ensure that they have an active surveillance programme for antibiotic resistance and antibiotic use. Also, antimicrobial stewardship and microbiology teams should ensure that their local laboratory is testing the bacteria against key antibiotics as recommended nationally, and also report their antibiotic resistance data to Public Health England.
That's right. So, thanks everyone. It's been a really interesting discussion with a number of thought-provoking concepts and practical tools that can be used. And if I can sum up, clearly we cannot afford to lose the power of our antibiotics. They are a vital tool for modern medicine and not just for the treatment of infections. We also need them to avoid infections during chemotherapy, cesarean sections and other surgeries. Unless action is taken to address the problem of antibiotic resistance, the routine operations could become deadly in just 20 years as doctors lose the ability to fight infections. The reality is we all have a role to play in ensuring responsible and less frequent use of antibiotics, and it will require the full commitment and engagement of healthcare professionals, the public, and other stakeholders in local authorities. In other words, everyone has a responsibility and everyone has a role. Thank you for joining us.